Welcome, everybody. I'm so delighted to have Dan Tsai with us today. Let me tell you why I'm as excited as I am. Federal and state governments, and even governments that are colonies, like the District of Columbia, play an incredibly critical role in our individual and community health. The pandemic has certainly shone a spotlight on how government policy can hinder or support public health and hospital systems. And as we're moving into the next phase of the pandemic, sadly, it's highlighting the challenges that our behavioral health system faces in meeting our needs, particularly those of our children. But even before the pandemic, Children's Law Center has been acutely aware of the ways in which both the actions and the inactions of government impact our children's health. Our vision at Children's Law Center that all DC children have stable families, good health, and a quality education is based on our understanding about how each of those three is inextricably linked with the other. Before we talk to Dan, I want to share the two initiatives that Children's Law Center has, which are focused explicitly on children's health. Our medical legal partnership, which is called Healthy Together, has embedded lawyers inside community health clinics around DC since 2002. And I'm really delighted that so many of our medical partners, those from Children's National, Mary Center, and Unity Health, are in the audience today. I'm also pleased to welcome our Medicaid partners from AmeriHealth, from HSCSN, and from the Department of Healthcare Finance. Our other initiative focuses on reform of our children's mental health system. For more than a decade, our staff and our clients have cited the lack of timely, quality behavioral health support as the top barrier to children's well-being. We lead a coalition of parents, advocates, experts, and providers who have recently issued a call to action, a report that outlines the steps we need to take as a city to ensure that the behavioral health of all of our children is met. We're committed to implementing the plan along with our extraordinary partners. Today, I'm honored to bring you together for a conversation with the nation's top Medicaid official, Dan Tsai. Before becoming director of the Center for Medicaid within CMS, Dan led the Massachusetts Medicaid system and is credited with really significant reforms and improvements. And as he pointed out to me before we started, it means he's seen both the federal and state side of how Medicaid works. We are going to make time for audience questions. At any point during the presentation, please feel free to ask a question using the Q&A function, and we will get to your questions near the end of the discussion. Welcome, Dan. I would love to start with really a framing question, which is, I think we all understand the concept of health insurance, right? We go to the doctor and our health insurance company pays the doctor, or doesn't pay it all, but pays some of it. Other than being health insurance for low-income children and families, can you talk about what Medicaid is and what, particularly in the realm of low-income kids, what the Center for Medicare and Medicaid Services does?
Sure. So, well, thanks for having me I was going to say this morning, but I guess it's actually just tipped over into the afternoon.
Yes.
And it's great to see what you all are doing. I see Rebecca Brink, who is your former colleague and my former colleague, and still at the Commonwealth of Massachusetts on. I don't think I can chat on this, so hello, Rebecca and others. Medicaid and CHIP. CHIP stands for the Children's Health Insurance Program. I would say, number one, it's an exciting time to be in Medicaid, and I love Medicaid. I hope everyone loves Medicaid and healthcare coverage for kids. And we cover over 50% of kids in the country, and in some states and areas, far over 50% of kids in the country. So Medicaid is really a bedrock when it comes to healthcare coverage and the safety net. But kind of as you're indicating, we do much more. And so within Medicaid, most folks think of health insurance and Medicaid as your classic health insurance pieces. Go to the doctor, primary care, some specialists, hospital care, pharmacy. That is all really critically important, and very much so for kids and a whole range of kids with range of complex conditions as well. Medicaid also does a lot around home and community-based services. So a range of supports for individuals. Some of them are very clinical in nature, like skilled nursing. Some of them are around personal care attendants and other things that really help with the activities of daily living for a range of individuals with disabilities. And some of the most specialized programs in Medicaid involve a fair amount of sometimes 24/7 supports that help children and kids with a range of disabilities or special needs be able to live as independently as possible in the community. And then I consider this part of, core medical care, but it's worth calling out behavioral health care as well, which oftentimes from a system standpoint ends up being so silent, and mental health in particular, but is really, really critical as a core part of what Medicaid does and what we have an opportunity to advance, and where we have a lot of challenges, to be frank. I know you all do quite a bit of work on that. And then finally, I think a really important piece that we from this administration have been trying to advance is how we think about Medicaid in the context of whole person care and equity. And so, as we know with kids, there are a few places where you can kind of think as upstream with long-term impact on not only health outcomes, but economic disparities and a whole bunch of other factors. And that fundamentally involves thinking about some of the health-related social needs or social determinants, if you will, and a lot of questions about what is Medicaid's role, both from a care delivery expectation standpoint and in some cases a financing standpoint, of where it makes a heck of a lot of sense to utilize Medicaid more broadly than thinking about very narrow traditional healthcare services, because there's a very clear linkage to health and equity and downstream outcomes. So those are all things that we have been working a lot on, and in many parts of the country are a very core part about how people think about Medicaid and CHIP services for kids.
Thank you. And before we dig into a few of those areas more specifically, CMS is a federal agency, but DC has our own local Medicaid agency. Can you talk a little bit about the division of authority between the federal and state governments, and especially when it comes into what services are available for kids and families?
So I think Medicaid is probably the most complicated, beautiful, challenging dance of federalism that exists in the country. And many of you will know this intimately. For those that are less familiar with the regulatory and statutory mechanics, the Medicaid program is jointly run by states and territories and the District of Columbia and the federal government. There's federal statute and oversight and regulation and around what are the minimums for what states need to be able to do on it from the Medicaid standpoint. That includes certain coverage benefits and things that are mandatory in nature, and other elements of implementing various statutory and legal things. And then within that, states have a fair amount of flexibility on how they do that. For example, many optional benefits, or how broadly to offer certain benefits, or what rates to pay, or how flexible to be on certain things, or whether to use managed care or fee for service, or all these sorts of things. Those are not things that the federal government, from a statutory standpoint, can mandate with states, but there is a strong partnership and dance, if you will, around kind of negotiating some of these elements. And so many times for folks on the ground in a particular state, there's both a lot of excitement of stuff of what can be driven at the state level, and some of which requires, can CMS approve that to authorize, the federal government and states share in the financial matching of all expenses for Medicaid. And then we at the federal government also get lots of questions about, hey, why can't you tell states to do this or that? And the answer is sometimes, yes, that makes sense. And sometimes we have no statutory authority to do that. And it is a dance about how to partner and encourage and kind of move the system forward. And so, having been both on the state side and the federal side, it's quite interesting. At the state side, I wanted CMS to say yes to everything that I wanted to propose, that we wanted to propose, and not say no to anything I ever wanted to do. And on the federal side, you have a different statutory role and obligation in how you think about the strength of the Medicaid program across the entire country.
So why might, from both sides, from the federal side, why might you ever say no? Why not just, if a state wants to do something creative and pay for things, why would you say no? So
I think one core part, which is very different than at the state level, so much of the federal Medicaid program is defined or has parameters relative to what we are authorized in our enabling statute to actually have Medicaid federal dollars go out for, and the implementing regulations of those statutes. And that puts a substantial set of guardrails around pieces where there's quite a bit of federal oversight as well from Congress and from other entities. And so in many cases, gee, we'd love to do X, that makes great policy sense. Our statute doesn't allow us to do that in a certain way. And federal dollars being matched around that, regardless of how lovely we think certain policies are, just can't go out. And so what happens in that case? Well, that's when we engage oftentimes in the budget process or with our colleagues in Congress to propose all sorts of statutory expansions of things that authorize the Medicaid and CHIP program to be able to do more. And that is a very important part of the process. And then sometimes there's a certain set of things, as you're aware, through Section 1115 demonstrations that can be authorized that are unique, but even those have parameters around what types of things you can or can't do. So that's very much the challenge and the beauty of the Medicaid program. And true north always is, how do we define from a federal standpoint an exciting direction for where we want to go? And that includes strengthening coverage and access and health equity and whole person care, and having a vision and a narrative and using every lever we have available within our statutory authorities to partner with, to encourage, to cajole, to argue with, and just ultimately support our state partners in, implementing Medicaid across 56 states and territories. So that's what the day-to-day feels like.
Well, let me ask one follow-up question about this before we delve into some of the actual specific subject matters that people care about. My favorite acronym of all of the alphabet soup that I live in is the SPA, the State Plan Amendment.
Would you like to go to a spa?
I would. I wish that it meant going to a spa. I will say, from the role of an advocate for kids, one of the biggest barriers that we often face is the need to submit a state plan amendment. It's not just a work to get our very busy state level Medicaid staff to actually make the time to be convinced that they need to do it, but we have wonderful partners at that level, so they often do. But then it's a very long wait for CMS to actually approve it. So I'm wondering, it sounds like SPAs are partly necessary because we have to make sure that what we want to do is within you have legislative authority. Is there anything that can be done to make this easier and quicker? And is that on your reform agenda?
Well, and I see Colleen Sanoski from the DC program on. So I guess anything you don't like, you can go talk to Colleen. Anything you like, you can talk
to
No.
Colleen is our wonderful partner, but why are you putting so much work on her? I think that's the question I have.
So I'd say a few things. For much of the Medicaid program, not all, there are a range of, you get an alphabet soup about how Medicaid is implemented through various authorities. The predominant version is what is outlined in what is called the state plan. Every Medicaid program has a state plan. Those state plan are things that are have mandatory and optional coverage pieces that are outlined in Title 19 of the Social Security Act. So the enabling statute for Medicaid, and the same thing exists for CHIP as well. In order for federal dollars to flow, the federal match, states need to have an approved state plan. And so every time you modify part of the state plan, it's called a state plan amendment or a SPA. So maybe sounds more pleasant than it actually is around that. But that is the legal vehicle to allow federal trucks to leave Fort Knox with the goal to get to state now around that. And so and there are time clocks around that and so on. And so ideally, those things can be as routine as possible. There are hundreds and hundreds and hundreds at any point in time that are coming in, given everything in the Medicaid program comes through that. I think the routine ones end up being very quick. I think where there are interesting creative ideas being proposed, that's where oftentimes what happens is there's a whole federal clearance process to evaluate the policy, to make sure everyone can read the statute and regulations, to make sure they're authorized, to debate back and forth with the state, to make sure that kind of the details are clear. And my wish and dream would be those things would happen, almost instantaneously. They don't always, because sometimes the issues are complicated, and in trying to get to yes, it requires quite a bit of questions and kind of gyrations to try to get to a good place.
Great. Well, let's dig into a couple of the big areas where Medicaid makes a difference for kids. As I think you know, Children's Law Center has been working very hard to get behavioral health programs into every single DC school. And this year, we have met with great success. One of the barriers that we have for expanding that program to meet the needs of all of the kids who need it is finding enough dollars. I understand that one of your goals is to make it easier for schools to get reimbursement through Medicaid for services that are provided at school. Can you talk a little bit about why it's difficult and how you're thinking of fixing the problem?
So it's for kids' mental health, behavioral health. I think it would not be an exaggeration to say we're at a crisis point.
Yep.
The pandemic has exacerbated that, but the challenges existed well before.
Yeah.
And when you think of where our healthcare system writ large has failings, like you intersect some of these things, and kids and mental health, and often kids have a confluence of other things where you have multiple state agencies, you have foster care, you have a Medicaid agency, you have SNAP issues going on, you have sometimes various disability agencies, local school districts, and all for good reasons, different regulations and authorities and people and agencies. But the issue is kids get stuck in the middle around that. Right. And then you get to availability of mental health services, which exacerbates all of that. School-based Medicaid is a really important piece of how to, advance equity, how to meet kids and kind of where they are, and to make sure to have both access and to finance some of that. And the president in the State of the Union of a kind of release of documents around that emphasized that we would be putting Medicaid an extra priority around this. So when you think of the challenges, and Medicaid, Massachusetts did, my former state did a lot of school-based Medicaid, and you sit and you talk with the schools, the clinicians, and others, you get into a range of things that end up being barriers at points. And some of that is Medicaid, as you referenced before, there are very specific healthcare requirements for documentation and billing in order to then draw down federal monies. And when you talk to a typical school clinician or an administrator of school, knowing how to document, it's hard. You'll talk to a lot of school nurses who may have practiced in a healthcare clinic before. They didn't have to do the billing around that. There are dedicated people figuring out what diagnosis code, what procedure code, what things need to be done so that things are auditable and you can trace. In a school-based setting, oftentimes they're having to do that all themselves. And they will say things to us like, I don't know what ICD-10 code to put down. Like, why am I figuring that piece out? And that's very fair. And so I think those are amongst many types of barriers that exist, and the fluency of schools to know the healthcare terminology and what has to happen, and vice versa. And so I think we have been engaging with a whole bunch of folks across that continuum to say, how do we try to simplify things? Where do we need to propose a new statute, meaning that we can remove some of the administrative barriers that would otherwise exist? Where do we have authority within the statute to try to make things more streamlined? Where do we need to help clarify across the country for a bunch of school districts and states and such for how people can leverage Medicaid dollars for a huge amount of school-based Medicaid in ways that aren't being leveraged today? I think DC does, does quite a bit of expansive stuff. Mm-hmm. And so a lot of it, I think, is probably in the details of how the school-based system understands the healthcare system and vice versa, and how to bring those two parts together in service of more access for kids, including mental health.
We often hear from schools that the cost of submitting for Medicaid makes it not worth it. That they're not going to get enough money back for the amount of time and effort it takes, which makes me ask, I know that there is always a balance between accountability and the kind of level of complexity that you're describing. Help us to understand why we have such complex codes and all within Medicaid. What's the upside of that, so that we understand the balancing act?
So, I mean, more broadly, outside of the school basis, I think I would say two things. One, I think probably most people would say if we were redesigning our healthcare system from scratch, like, you probably wouldn't end up with exactly what we have now, and in particular, this very fee-for-service oriented world of tons of documentation, and sometimes the administrative overhead of things ends up being so substantial that it's just not productive, and often you end up chasing or only being orienting clinical practice in healthcare delivery more around what is billable versus where and how to meet individual family and patient needs.
Yeah.
And so a lot of the question about value-based care is less around, hey, let's put providers at risk. It's more about how do we try to think about more flexibility, say for a pediatric or primary care practice, to be, for example, we're engaging with one state on this, to guarantee like a fixed amount of funding so that they can engage in all sorts of ways that are more effective versus you got to get the parent with the kid to come in for the 15-minute office visit on this day because that's the only way you can get submit a claim for it. And if you're engaging with a social worker outside of that, like those are not productive, but they are materially, this is beyond Medicaid, how our healthcare system is constructed today. And so I think that's one overall push. But when you take that over into the school-based setting as well, not only do you have going from 0 to 60 in some senses of like, again, like knowing the precise CPT codes and HCPCS codes and ICD-10 codes that are a standard part of healthcare required documentation and billing, and what's required within oversight from a federal and state standpoint, to how do we find flexibilities within that get at enough of the program integrity that is required, but really removes unnecessary administrative barriers that have the purpose of limiting care in these settings for no good reason than, you know, some administrative pieces. So I think that is a fair amount of dialogue and discussion we are having with the community. And you can imagine a lot of lawyers staring at statute and regulation to try to understand where there might be more flexibility around something like school-based Medicaid.
It raises a question for me, which I've been hearing from some of our, we have, as you know, MCOs, Medicaid MCOs in the district, and actually Children's Law Center has a contract with one of our MCOs because we've been able to show that we help them avoid costs when we help to ameliorate housing conditions. So they've been very innovative. This is AmeriHealth DC, and we've been working together really quite fabulously. But one of the things they shared with us is there are very few community-based organizations that can, I mean, we have, of course, had to become HIPAA compliant. There were things that Children's Law Center needed to do that even as that were hard for us because we're not a medical provider. But it gets even worse if you want to move some of this care much more into the community and smaller organizations. So let's turn to that and sort of how Medicaid can begin to address social determinants of health. Because I think, as we all know, the research is very strong that health, especially for kids, food deserts and access to fresh food and domestic and community violence impacts kids and families' health dramatically. And how do we give flexibility through Medicaid to address those issues in order to save us all dollars in addition to improving health?
So I think I'd say a few things. So I think one, in terms of the social determinants, one of the ways we really want to encourage ourselves and everybody think about this is around 3 parts, right? Because we do believe addressing the health-related social needs like housing instability, nutritional instability, employment supports, things of that sort are critical to health outcomes, advancing health outcomes and closing disparities. So the 3-part thing is we want to embed more in Medicaid care delivery expectations for addressing the social determinants. And that first piece involves, assessment and screening, identifying where there is housing or nutritional instability, connecting people with the right community organizations, having that be a part of care plans, having that be a part of routine expectations for what health plans and providers would do versus, we only think about the medical, like physical healthcare stuff and all this other stuff someone else should think about. So regardless of what Medicaid can pay for, that being a core part of what is the purpose of care delivery and coordination, et cetera, through Medicaid. Second piece is quality measurement to try to track the incidence of, in a consistent way across states, of housing and nutritional instabilities, the extent to which state programs and health plans and providers are able to actually assess and then refer and actually help address some of those needs. That's important to document and make progress on. And then third is the ever-present question of what can Medicaid dollars get used towards? And I think that's where there's a lot of debate, again, looking at the statute and seeing where we can provide some more flexibility around things around housing supports and nutritional supports, et cetera. There's a fair amount of precedent for Medicaid doing more around this. In California, at the end of last year, we just approved through their managed care contracts a fair amount of flexibility for them to do a whole set of housing supports, nutritional supports, range of things through managed care based on some of the stat regulatory frameworks there. That is really exciting, and we've noted that CMS will be putting out some guidance soon that hopefully allows many more states with managed care to take advantage of that. And that's not to say we preference managed care, but managed care affords some flexibilities that we can just take advantage of. And there are a number of states with Section 1115 demonstrations, my former state included, where we did get authority as part of our delivery system reforms to specifically fund everything from housing transition supports, security deposit, first month's rent for folks, certain nutritional supports, all for certain targeted populations. Those are all pieces we want to kind of confirm or advance or figure out how we can kind of make a little bit more systematic across the Medicaid program.
And are you able to, are there results that come from this that then you can share with the rest of us? So if California gets good qualitative data, do you then have a mechanism for sharing that with all the rest of us?
I'd like to say yes without caveats, but yes, ideally. And I think, the evidence, I think every one of us can agree, right? Policy wise, it's hard to argue that addressing some of these things, or like air conditioners for kids with asthma, like it's hard to see how that isn't going to help on health outcomes. The ROI or the, the formal clinical literature on some of these things, some areas it's more strong, some areas like there's very little. And so that presents opportunity to test and to collect data over time. I don't know that we all have the resources to do that as systematically as we would otherwise like.
So one of the very specific issues that we face, and I think that children face, is that unlike adults, one of the most important things for kids are the adults in their lives. And in order to really provide good clinical care to a child, you need to talk to often other caregivers, parents, teachers, other medical professionals. At the moment, the time to do that isn't reimbursed through Medicaid. I'm wondering if that is on your radar as something to fix.
Yes, it's complicated, but yes. And
Say more about why it's complicated.
I think, well, if you peel out the layers of Medicaid, if you start with the state plan and fee-for-service, so without some of the managed care flexibilities and other demonstration authorities and so on, typically healthcare and Medicaid and the things we're authorized to pay for are very cut and dry. Categories of service, you can document a particular billing code and there's a fee schedule for it. And many of the things that you're talking about don't fall into that category.
Mm-hmm.
And so layer one is encouraging. There are states do have the ability to implement a range of collaborative care codes or other things within certain contexts that, for example, Medicare reimburses for, with social workers, with collateral, with a lot of the work that has to happen in the spaces in between various clinical and other folks from a case management standpoint. So that is an option states have, and we want to encourage states to take up some more. I think when it comes to even more, but that still has a defined parameter of what that looks like in a clinical setting. When you start to get even beyond that to more free form in certain ways, you end up saying, like, what is the structure that allows for Medicaid and federal reimbursement and state reimbursement? And you get into a range of delivery system models, things where you try to, like, provide certain payments for folks to do more coordination and entities who's accountable for that. Health plans have administrative dollars and some flexibility. So many of those things, I would say there are vehicles to make that happen if a state wants to advance that. It does require thinking about, am I trying to do that through managed care or fee for service? Who is going to get the payment? How do I write the specs in a way that is like you can touch and feel it and submit it to CMS to say, these are the types of services and things, and how do I know that's happened? How do I reimburse for that? Or, in some non-fee for service ways, here is a non-claims based way in which I'm going to think about reimbursement. So I would say that is there are avenues to have Medicaid support for that in the right context. A lot of it depends on state specific ideas and innovation to put forward, and then CMS staff and states kind of work together to see how do we get to something that is approvable around it. So that's why that answers part of your question, why some of these spots take time, because you're trying to sometimes put a square peg through a round hole and make sure that all the right, kind of conditions are met around that.
Got it. Well, I'm going to remind folks that you're welcome to put questions in the Q&A and I will ask them. Let me raise something which I talked to you about in advance. So it is a deeply held belief in DC that CMS prohibits same-day visits to both behavioral health and medical providers in different clinical contexts. And you said that's not right, and you guys are going to issue some guidance around that. I'm curious both to have you talk about that, but then also, how do you help to educate states and advocates about what CMS's positions are so that people understand that?
Okay, that's a great multi-layered question. On
Yes.
the first one, and I see again, Colleen, you should let us know offline if there are specific regulatory things or things that you'll have a different point of view on, or others in the DC sphere. On the topic of same-day billing prohibit, if someone has a primary care and a BH visit, a prohibition around billing on the same day for that, that obviously limits access. Yes. From CMS's point of view, there is not a federal limitation around that, and we are in the midst of working on some documents or guidance we can put out to states more broadly on behavioral health, inclusive of kids' mental health, that encourages states to consider a range of policies, all of which they have the authority for today, but CMS can't quite, require. And one of those encouragements will be to remove, to the extent they exist, same-day billing prohibitions for primary care and behavioral health. So that's, if we'd welcome if there's any confusion around that, which we can help to further clarify, et cetera, but that is the agency's position. It leads to the second part of your question, which is Medicaid's complicated. There's a lot of thoughts we have all the time from the federal standpoint, state standpoint. We have various vehicles of communicating that. A lot of that is live dialogue with states and the Medicaid directors and others, which we have a lot of forums for, and topics come up, put them on. Every other Tuesday, we've got about 700 state people on a call together, run through a list of things that we've heard. That's a good way to get some of that out. Where more formal stuff is needed, meaning it's helpful on CMS letterhead to explicitly state there's not an issue. If it's not a new policy issue, we enter center informational bulletins, which are not treading new ground on policy from the federal government standpoint, but just making sure if there's any, highlighting certain existing things or resources or policies that folks may not fully be aware of. It's usually a helpful way to spotlight certain priorities, like kids' mental health, really important. Here's some things to remind folks on, or lead screening or XYZ, not new policies, but a way to draw federal attention to some priorities. And then there's working through really new policy that we think the statute allows us, but hasn't been tread before. That's when we put out either a range of, they're called state Medicaid director letters or the like, or proposing new federal regulations that officially give the federal government day-to-day authority for how to advance those parts of the Medicaid program and specific proposals.
Got it. Before we get to a couple of audience questions, can you just talk for a few minutes? So there are two kinds, there's fee for service and there's MCOs, and DC is making the transition really to 100% MCO. And clearly MCOs have a lot more flexibility than fee for service situations. I just wondered if you can talk about your thoughts about states going to MCOs versus fee for service and what flexibility you see in that.
So CMS doesn't have a formal point of view of states should do managed care, they should not do managed care. States have the option to use managed care, right, which presents a lot of flexibilities. I think the most important thing from our standpoint is across the board, including for managed care, kids and beneficiaries can get access to the services that they're entitled to. And so that with the flexibilities of managed care, those are used appropriately, and also that there's sufficient network access and that folks are getting access to services needed. So, I think there's a fair amount of flexibility, and we do not take a formal position, because I think depending on state and context and whatever, like all of those models, managed care or not managed care, can be ideal, can be not ideal, can be used well, can be used poorly. And it really is a very individual specific, set of circumstances.
Got it. We have a couple of questions coming from the audience. One of our friends at Mary Center wants to know, and I'm going to read the question: does emergency Medicaid cover the cost of uninsured breastfeeding mothers to obtain electric breast pumps after delivery? And because our Mary Center friends are good advocates, she says, as you know, breastfeeding babies are healthy babies, and supporting breastfeeding mothers means greater breastfeeding success.
Well, I affirm the importance of, pumps, and I have a toddler and now going to be 7 months and 1 day.
Oh, you look like you've had sleep.
We have a few pumps lying around the house around that, and we are lucky to have access to that, and that's really important for everyone. For emergency Medicaid, that would be a question for the DC Medicaid program. I think if you're asking the question, probably aware of the construct of certain federal limitations for which only emergency services are authorized. Generally speaking, the federal government has deferred to states from a clinical standpoint of flexibility in defining what is the definition of an emergency or emergency services. And so states have fairly broad purview of that. They are subject to whatever, audit risk one might land in for whatever reason, but we have tried to accommodate states being able to take whatever definition they can think of for what an emergency service is.
So this is something which should be advocated with at the DC level.
That's right.
Got it. Okay, I'm going to read out another question. It's very specific, and I just want to say with the audience, we said to Dan, you have a very sophisticated audience. You might get a lot of very specific questions. Obviously, he may not be able to answer them all, but we're going to ask you anyway. Here's another one. SAMHSA has received hundreds of millions of dollars to offer time-limited grants for behavioral health organizations to become certified community behavioral health centers. ASPE's evaluation on December 23rd found positive impacts in Medicaid demonstrated states on cost and quality. One of the best ways to make these centers services more broadly and long-term sustainable is offering these services through Medicaid state plans. Not is, but how is CMS working to fast track the approval process for adding certified community behavioral health centers to Medicaid state plans? It's quite a question.
So it's a great question, Mark. And you'll see some ode to this and hopefully what we can put out before long on behavioral health. So I would say the clinical model for CCBHC, without question, is critical and really, really important, meaning much more integrated, broadened access for behavioral health services, integration between mental health and addiction treatment, much more focus in some cases around 24/7 crisis and access and evidence-based and trauma-informed treatment. All those things are absolutely critical. And I think we, from a federal standpoint, believe that is a strong and good model that we would love to see many states move in the direction around. And so we'll be affirming that. I think the question about, can it be like a state plan piece? Yes, we are working through various options around that. The main piece is states have various options for whether they want to take some of those things up. And there's a range of discussion around how we most make the clinical model something that we are encouraging. And certainly, I think states are in a range of places about what they think about the payment side of the house around that. And so there's some nuance there. We generally want to encourage and support more investment in behavioral health and broader access and more integration, which the CCBHC model really upholds.
Great. And I'm going to read aloud Mark's next question. Mark is one of our closest partners, as you can imagine. Can you also comment on same-day billing restrictions that might occur when a Medicaid beneficiary, particularly a child, needs education-related IEP Medicaid services, that's special education, through their special education plan.
Yep.
And also needs mental health or substance abuse treatment medication services. How might CMS strengthen the ability for Medicaid providers to offer different IEP and behavioral health services on the same day?
That's a very specific question that I think is probably specific to an individual state set of circumstances. I think generally I would say this without equivocation or caveats. We want to support as much ready access to care, including a range of behavioral health services, a range of things that might be on a child's IEP, offered in the school or non-school setting, all of that. And generally speaking, there are not federal prohibitions around same-day billing or aligned billing on things. Obviously, it depends on how a specific state has identified certain billing codes, because you can't pay for overlapping services. But a lot of this becomes, how does one define services? So like if you get a range of things on the same day, like you can bill for it, they're not overlapping, shouldn't be. And so we strongly support that. And I think a lot of that nuance comes down to certain individual specifics for how a state has structured reimbursement and the parameters that must be met. So it's a great question. And I think, we'd welcome if you have thoughts from a federal standpoint on that. And I'd be very interested in hearing kind of where our DC colleagues would be on specific applications in DC Medicaid.
That's great. So we've talked, it seems to me that an overriding theme here is Medicaid is both critical to children's health and unbelievably complicated. And that it really was built at an earlier time in a model that isn't how we think about health today. Like that as we're talking, there's a lot of workarounds being tried in order to manage the complexity and then the reality that we understand today. So I guess my big overarching question is there any discussion of a fundamental or transformational change to how Medicaid operates in order to address sort of the complexity of all of this? And it operates a little bit like a traditional health insurance model, or is that just not politically feasible right now?
So I would say many of these issues, like the fee-for-service pieces, are no different than what private health insurers and Medicare have to deal with. That is the nature of the healthcare system. I think we, from a payer, from a public standpoint, are trying to go much further in how we integrate, given the population we serve, a range of things that often aren't discussed from a reimbursement standpoint, right? In other payer health insurance settings. And so I think a significant portion of the complexity comes from the fact that Medicaid is both one integrated program and 56 individual programs. And, it is a delicate, beautiful dance, because some of the back and forth enables, from this administration standpoint, we want to make sure there's an appropriate floor for Medicaid across the country. And some of the partnership and push with various states is where we think there's an obligation for Medicaid and CHIP to do more. And then in some cases it is, hey, great proposals, and we're trying to figure out how to get to yes, but there's certain boundaries around that. So that is part of the federal oversight piece of making sure there's a strong Medicaid program across the country.
That's great. And I just want to share that what's wonderful about having us all in the same virtual room is Colleen, being as thoughtful and wonderful as she is, has just said, we need to look at this and figure out from an operational side, because I agree with Dan on the same day billing policy wise, this is a problem to solve. And I think that it's a high priority for everybody. So thank you, Colleen, for being willing to sort of think about that. We have another question, which I think is in the same vein, not particularly about behavioral health, but about sort of the complexity. So it's, what steps can we take toward alternative payment models that improve child health and development across health and human sectors like child welfare?
I think the answer is yes. Work with the state to propose something. I think, like I said, there's a fair amount of flexibility, but a lot of it involves kind of where a state wants to go. From this question here, I can see 15 different ways one might want to structure some things, some which we could land Medicaid dollars on, some which would be more challenging, but a lot of that is a question of kind of where a state would want to go on the structure of, say, an alternative payment model that encompasses a broader set of things here. So like, I can't, for example, if it is around healthcare services for providers, an APM, alternative payment model that tries to measure a range of longer term health and development metrics, ACE events, health disparities over time. That's excellent. I think we strongly support and want to figure that out. You immediately get to questions of, well, some of those metrics take like a long time. You don't change child development trajectory in 18 months, either at an individual child or a population. So how does one structure things of that sort in a way that we can kind of formally get to yes on? And so I encourage folks to be able to come up and propose some of those things. And that's, again, part of the beauty for why there's so many flavors of Medicaid all across the country.
Do you have thoughts? We have a lot of advocates on the line. Ideas for advocates, what you've seen advocates do successfully to help states make it easier to recover Medicaid or be good partners in this work?
Well, you can go bug Colleen every day. That would probably.
You already do.
I think so. Advocacy is a beautiful and important thing. And I think it's sometimes there, I think of Martin Luther King's, the arc of the universe bends towards justice, and there are scales of justice and pendulums and all these things. And I think usually the answer in life when it comes to health policy, even when everyone is aligned on the same set of goals, is that it's complicated and there's nuance and you need to make trade-offs. However, how folks figure out where to land some of those trade-offs, I think fundamentally gets shaped by where there is really strong advocacy. And importantly, when and if that advocacy also brings very concrete solutions and recommendations to, say, state Medicaid program, and also where there is alignment, meaning providers or plans or others can also describe, hey, here's how we would do it. And then the state can start to say, well, is that operationally feasible? What's the, can I manage the fiscal piece? Can I figure out how to code the systems for it, et cetera? And so I think that is a really important process. And generally, that discussion doesn't lead to everything that, from an advocacy standpoint, we'd all want to see, but leads to some progress, hopefully more than just incremental progress. And so I think advocacy itself, just having folks focused on kids' health and some of the specific issues, including on mental health and school-based Medicaid that you all are focused on, and the integration, how it fits in with other child welfare and other topics, I think is critical. I think to the extent, including some of the questions that are really good I saw today, that you engage with the state Medicaid agency around specifics and getting to alignment around that. I think, Colleen can weigh in the chat if she agrees or disagrees, along with her DC Medicaid colleagues. But I generally think that that's a good way to try to figure out how to get some stuff done.
It is. Well, and one of those issues that we do work collaboratively on is workforce. And I don't know how I managed not to ask you about this earlier. Obviously, nationwide, we're all facing problems with not enough clinicians, especially in behavioral health, but across the board. Curious what CMS is thinking and doing in that area.
So I wish I had a better answer, because every day I wish we could, when we have our internal discussions, gee, how do we solve the workforce crisis across the country for healthcare, especially in behavioral health, and then also home and HCBS, home and community services. I don't think we alone can. However, we want to help support and enable that. Clearly, rates and investments into providers to be able to pay rates and wages to retain a workforce is really critical. In behavioral health, unfortunately, that's a necessary but not sufficient condition. Like, you have, I don't know what the stats are nationwide in Massachusetts, I think like only half of behavioral health clinicians actually accept insurance, and even less accept Medicaid. And so it's not even, pay. So reimbursement rates at any level you could contemplate a Medicaid agency going up to sometimes pale so much compared to private pay and so on. And so I think there are other things to contemplate, like Massachusetts, through our 1115 demonstration, when I was there, we had gotten authority for loan repayment, retention programs, where we could offer grants to individuals and clinicians who would go work in safety net providers for a certain amount of time. Those are incentives to help ensure there's workforce. I think there's great appetite for us to consider more state proposals on that and other things where, in addition to rates, other things that might help on some of the workforce challenges.
Great. We have a question that I don't fully understand from one of our friends at Children's National. So how can we assist or assure that potentially WIC eligible, I guess it's potentially WIC eligible women are captured to mitigate food insecurity among Medicaid recipients?
I assume that question extends to both WIC and also SNAP as well. And there are various forms of WIC and SNAP gaps. Either way, right? You look at individuals and kids and adults on the Medicaid caseload in any state at an income level that seems to mean that they should be eligible for a range of benefits, including SNAP or nutrition or kind of WIC and things of that sort, but they aren't. And that is a gap, and trying to figure out how to close that gap. And there are a lot of things, policy and operational, and simplifying how hard it is to get various benefits is one part of that. And then vice versa, we see that as well. Folks say on SNAP or WIC who otherwise seem like they should be eligible for Medicaid, but are not on Medicaid. So I think that there's a fair amount of discussion at the federal level across agencies on how to support states on that. Again, you bang up against some complications, but I think that is something we want to figure out how to advance.
Great. So as we're wrapping up, I realized that I never asked you whether there was something you wanted to share with the audience, that your personal priorities or anything that's going on right now related to kids and families that you wanted to let us all know about.
Kids and families, and in particular, the intersection of that with mental health, behavioral health is a top administration priority. From the White House to the department, HHS to CMS as an agency. And so many of the things you hear underlying my comments are fundamentally oriented around that. And so we have three big themes at CMCS, Medicaid. That's first is coverage and access. Second is health equity. Third is innovation and whole person care. And all those things orient to things like how do we make sure kids get and maintain coverage, especially with the PHE unwinding, whenever the public health emergency ends and some of the eligibility protections, we are very concerned about making sure that kids in particular and everyone can maintain coverage, either in Medicaid if they're eligible or transitioning elsewhere if they are no longer, but that we don't have folks without coverage. And that there's a fair amount of work we have, and we just had a request for information out, and I think there's a public schedule that we're contemplating rulemaking for access and standards we can apply and how we make sure that kids and mental health access is strengthened. And then we talked about school-based Medicaid and how we do much more around that. So those are some very key priorities. They involve a lot of discussions with states and stakeholders, and some of it involves pushing out federal guidance and requirements. Some of it involves figuring how we can support a lot of the innovation, including on some of the social determinant aspects that states are wanting to do, and we are wanting to figure out how we can partner with those states.
That's wonderful. Thank you. So my biggest takeaway here is that if we could only get the DC Council to put more money into cloning Colleen Sinofsky, that CMS, Medicaid is big, and we could be getting more if only we had more folks at the state level to open the doors, and Colleen and her colleagues don't have enough hours in the day. So we will work on that. No, seriously, I do really appreciate your taking the time to talk with all of us. It's a complex system, and it's helpful to be able to see the big picture. As I say to everybody whenever they join a community conversation, please stay involved. We have so many of our current partners as part of this, and I so appreciate your partnership. If you're a lawyer, you can always do pro bono work with us. Everybody can become a donor and allow us to do the work we're doing. And no matter who you are, you can join us on September 20th when we will be in person together, we hope, celebrating what we can all do as we make these reforms and as we work together to improve kids' health. So thank you, Dan, for joining us, and for everyone for tuning in.
Thanks for having me and for what you all are doing. Appreciate it.
Thank you, Dan.
Take care.